Hello everyone, and welcome to my quality improvement project on hand hygiene compliance. The quality problem identified for my project is that athletic trainers at Deerfield High School do not utilize hand hygiene or table disinfection techniques often enough after patient care. Lack of hand hygiene and table disinfection can promote the spread of potentially harmful microbes between athletes. The goal of our project is to implement specific hand washing and table disinfection protocols for the athletic trainers at Deerfield High School that includes the frequency, duration, and methodology, and to increase AT compliance with these protocols. The quality improvement team members involved include athletic training staff and other support team members. The athletic training staff consists of Caitlin M., Lorenzo C., and Gabriella C. Other team members include Lauren C., who is the coordinator of AT services with athletico-physical therapy. Her role is to assist with the protocol design and compliance. We also have Robert R., who is the Deerfield High School athletic director. His role is to assist with coordination and implementation of the protocol. Finally, we have Dr. Letvin, our team physician. His role is to assist with protocol design and implementation. We aim to create, implement, and track hand hygiene and table disinfection protocols for the athletic training facility at Deerfield High School to reduce the spread of potentially infectious pathogens, increasing compliance by 50% over the next 3 months. This aligns with SMART criteria as it is specific because the population, timeline, and goal objectives are clearly identified. It is measurable as the frequency of compliance can be tracked. It is attainable as all ATs will collaborate and support one another in this quality improvement goal. It is reasonable as hand washing and table disinfecting are simple, effective measures at reducing pathogens. It is timely as 3 months is an adequate time to determine if this is an effective effort and if it is successful and can be continued into future school years. This is our current process flow chart outlining the current day-to-day operations at our athletic training room, highlighting the quality gap. Note at the bottom, after the athlete leaves the athletic training facility, you have the question, was contact made with the athlete? For every arrow that has yes coming out of it, all 3 of these are currently outcomes that happen. Either hand hygiene using soap and water or alcohol-based hand sanitizer is used, or the table is cleaned, or there is no intervention. The gap in our system is that the no intervention happens far more than the hand washing or the table disinfecting. Our goal is to increase the hand hygiene and the table disinfecting and to reduce the no intervention after contact was made with athletes. This is our cause and effect diagram outlining how our policy, people, methods, and materials all lead to the same problem, which is that athletic trainers do not adequately implement hand hygiene or table disinfection. Our company policy is very vague as it instructs to wash hands after using the restroom only and does not instruct when to wash hands after patient care. Under people, we have 2 to 3 athletic trainers after school on a given day to treat our 600 spring athletes, many of whom come in for treatment at the same time within a half-hour time frame, leaving only 2 to 3 people to treat many at the same time. Under methods, our tables are currently disinfected only at the end of the day unless visibly soiled, and there is often no hand hygiene technique used between athletes, as I just demonstrated on our current flow chart design. For materials, athletic trainers often use alcohol-based hand sanitizer instead of washing their hands with soap and water. While that is still hand hygiene, we would like to implement soap and water more so than alcohol-based hand sanitizer. Also, a lack of table disinfecting materials helps cause this problem, as we only have 1 bottle of our cleaner for all 6 of our treatment tables. This project aims to outline the following improvement measures. For process measures, we aim to find the rate of hand washing after patient care and the rate of table disinfection after patient care. For outcome measures, we aim to identify the ratio between the number of athletes treated to the incidence of hand washing or table disinfection, giving us the total percentage of hand washing use in the facility and table disinfection use in the facility. We also aim to find the incidence of skin infection after implementing the hand hygiene and table disinfection protocol, which will give us a sense overall of how successful our improvement project was. The changes we aim to implement are that athletic trainers will wash their hands after 3 criteria. The first is coming into physical contact with an athlete during treatment. The second is touching a surface known to be contaminated by possibly infectious pathogens, such as touching a treatment table after providing first aid. Third, after an athlete with a known skin infection has been treated in the athletic training facility. Athletic trainers will disinfect tables after 3 criteria as well. The first being an athlete finishes their treatment on the table. The second is bodily fluids somehow get on a table. And the third is an athlete with a known skin infection, again, has been treated in the athletic training facility. Outlining our Plan, Do, Study, Act cycle. To plan, we will get approval and create hand hygiene and table disinfection protocols. The do portion will be implementing protocols and collecting the data. This will be done via a Google Sheet where all 3 athletic trainers will implement their data at the time of collection. The study will be to analyze data and determine if our project aim was met. If not, we will identify those changes that need to be made, and if so, we can move forward to the act portion, which is to adjust protocols and methods for future cycles. This is also where our spread plan will come into play. Outlining our spread plan, after implementing as many PDSA cycles as necessary to be successful at Deerfield High School, we will then move to School District 113 as a whole, which encompasses another high school, Highland Park High School. In order to do this, we will share our data with their athletic trainers, athletic director, and coordinator of AT services, as well as their team physician. We will implement the Plan, Do, Study, Act cycle specific to their AT facility and student needs as many times as necessary to become successful. From there, we will spread even further to the near north region of Athletico as a whole. To do this, we will share all prior data with all of the athletic trainers under the coordinator of AT services, Lauren C. We will then plan and implement multiple PDSA cycles as necessary until protocols are in all settings within the region. There are 19 athletic trainers in the near north region with athletical physical therapy. Finally, we will spread this to the athletic training department of Athletico Physical Therapy. We will share all prior data with every coordinator of AT services and manager of AT services. We will again implement multiple Plan, Do, Study, Act cycles as necessary until protocols in all settings that are overseen by each manager of athletic training services and coordinator of athletic training services. I enjoyed being in class with all of you this block, and I hope you enjoyed my presentation.